as I said earlier, my name is Sandy Spivey, and I'll be facilitating or helping facilitate this breakout session about HER2 positive breast cancer. We will have some time for questions and answers. So in your packet, you should have some cards, and if you need some cards, you can get them from Sharon. And where is Sharon? She is out of the room. She is right at the back of the room. Anyway, Sharon, who's holding the door open with her back to us in the pink shirt, has more cards. So if you need them, you can get the cards from her. And at the end of the session, we will have the Q&A. So I'm not going to tell you my personal story with metastatic breast cancer, but I'm going to tell you about my relationship with my oncologist, Dr. Farah Brasfield. She is my oncologist. Yay! She's the one who was holding that 8-foot-long paper that had all the treatments that I've been on ever since. And there have been times when we've just sat in the room and said, what do we do next? Well, there could be this, there could be that. What do you think about this? Okay, well, and then I say, well, what do you think about that? And then we'll go back and forth and back and forth. But her appointments always last longer than the time that is allotted. And so whenever you see Dr. Brasfield, you always have to wait in the waiting room. So we always bring stuff for us to do. You always have to wait. You just have to wait. But you wait for something phenomenal. And it's worth every minute waiting. And I will wait the next 20 years, hopefully, of my life, if I need to, for Dr. Brasfield. She is serving as the Chief Hematology Oncology Department for Orange County. So she's responsible for oncology in the Orange County area for Kaiser Permanente of Southern California. She has been a researcher. She has worked in the labs. She decided she wanted to go and treat patients. But even as a clinician, that's an oncologist, a clinician. They were talking about clinicians earlier. Same thing. They work in the clinic, clinician. She also does research, and she also contributes to research, and she also has been part of many very extensive research projects that have been very successful. So she wears many hats. She's a very busy woman, and I'm so grateful that she's here with us today. So with that, I'd like to introduce Dr. Farah Brasfield.
Thank you. Thank you very much. Can you guys hear me? Oh, okay, very good. Well, I'm honored to be here, and I'm honored to be an oncologist. Cancer has afflicted my own family, and frankly, every patient that I see, I do feel that they are me, they're my sisters, they're my mothers, they're my children, and I do feel connected because of the journey that I've personally taken with my own family. And I know how much bravery it takes to be a cancer patient. And I get inspired every single day by every patient that I see. It is a remarkable journey that as a team of doctors, researchers, and patients, we take together. I consider cancer journey and cancer treatment as a team sport. And the more information you have, the better you can work with your team. So I very much honor and support what organizations like Susan Komen Foundation does. And I thank them for inviting me. This is a great opportunity for me to converse with you today, particularly on HER2 positive breast cancer. I consider Sandy as my friend. 20 years of being together and, involved with her family. The first day Sandra met me, said, do you think that I'm going to see my daughter graduate? And at that time, I believe you were 12 or 13. I've shed tears with my patients. I've carried their burden with me. At the same time, never ever got depressed by it because it just inspired me to work harder. and to learn more and to educate more and to inspire our patients to get into clinical trial. You heard about clinical trial today. That is the hallmark of our success. And I am going to present a lot of trials that has been done, particularly as it relates to HER2-positive breast cancer, so that you would see how clinical trials has guided physicians like myself and my partners in helping our patients. When Sandra and her daughter went to New York, I believe, as a daughter and mother, that was one of the plans you had. It was like the happiest day of my life. And that was, I believe, when you were in your 30s or 20s, late 20s? DC. So, living life with the journey of a cancer patient is remarkable. You measure your successes by different parameters. And nothing is more heartwarming than the humanism part of that cancer journey. Seeing successful attendance to graduation, seeing successful attendance to achievement of the loved ones and the relationships that are built and the places that they've seen is part of your journey as a physician. And I celebrate that every day, and it makes me keep the tough hours of late nights and weekends, and especially Sunday mornings when everybody in your own family is asleep and you're studying the journals in your mailbox. So I will summarize those journals in what I've read for you. So what is HER2 breast cancer? HER2 stands for human epidermal receptor. And if you would notice on the right-hand side, on the left-hand side, these epidermal growth receptors are on the cell surface. This is a cell, and on the surface you have these. A normal tissue has that. And initially in 1987, you heard this morning how long it takes to get a drug to the market and to see if that drug even works. But it starts in the lab. The lab in 1987, I have to tell you, in 1986, I was actually at MD Anderson as a student working on fluorescent in situ hybridization, the technology that actually detects HER2 receptor on a surface of a cell. So you extract that very tiny molecule, the DNA, and you end up making it, putting it through a process and then highlighting it with a marker so you can detect the surface of these cells. Normal tissue has about 25,000 to 50,000. In a cancer cell with HER2 overexpressed, you would see 2 million on the surface of those cells. And what it does, it makes that cell divide right here, in here, uncontrollably divide, and it just feeds that cell. So obviously that journey took from 1987 in a PhD lab all the way to 1999 and 2000 to a point that we ended up on pathology slides of a tumor looking for them through 2 different technology. Immunohistochemical testing, and you may hear that, your IHC came back 2+ or 3+ or 1+. We need to retest it if it is low and get into the fluorescent in situ hybridization, which is here. You notice I have fluorescent in situ hybridization, and also there's a chromogenic in situ hybridization that is somewhat new. This technique is fairly cheap and doesn't involve that much work in a laboratory. So a normal tissue may be like this, somewhere a little bit of that HER2 may look like this, a little bit more like this, and a lot is like this. That's the 3+. So that's readily available, but it has some flaws. You don't get always all of the tissue remaining as you're processing it, and it may just degrade. So for that reason, sometimes you have to, if it is not 3+, you have to verify it with this technology, FISH fluorescent in situ hybridization. This is a negative one. This is a positive one. And this process is very laborious in the laboratory. And it's expensive. So a new technology somewhat in between has been coming about that you may hear, chromogenic in situ hybridization. That's somewhere between staining with a different peroxidase and looking at the histopathology of it under the microscope to correlate it. That technology is still not validated, but it is meant to bring it, bring the cost down and bring availability across the country in regular pathology labs so that that could be done. Just in case I'm trying to give you different, things that you may hear and why we're using it or we're not using it. Those two tests that I mentioned, they are validated. And right now, the standard is immunohistochemical testing in the laboratory. And as I said, it may be totally negative or 1+, 2+. 1+ is still considered negative. And if it is 2+, it's not confirmatory yet. You need to go through the in situ hybridization, and that's the chromogenic in situ hybridization. If it is 3+, you actually get to the drug, the target drug you want to use. And obviously, by fluorescent in situ, you would go through negative and positive, and if it is positive, you will get the Herceptin targeted drug. There are also equivocal testing results that could happen even with fluorescent in situ hybridization that now there is a standard way of approaching throughout the country, and we're able to actually tease those out and even repeat those testing if needed. Anytime physician is concerned that the test may not really reflect the behavior of that cancer cell, they can actually repeat the test in a different part of that tumor tissue or in a new biopsy. So breast cancer in 1995, all we knew at that point that people that had HER2 positive testing, they behaved a certain way. They had shorter overall life expectancy. They had earlier relapses that resulted in shorter life expectancy. And we recognize that they do require for response, the HER2 testing is required for response for the HER2 response for anti-HER2 Herceptin drugs. And if you don't have that and you give Herceptin to somebody that does not have HER2, they will not respond. And I have graphs to show you that. So what has been the progression of our knowledge base based on all the studies that have been done? In 1998, we completed and reported initial randomized trial demonstrating benefit of, right here, far left, benefit of a drug called trastuzumab, which is Herceptin, as the first anti-HER2 antibody that we ended up using. And then we started, when we saw it was very effective, we started using that in before operation. This is called neoadjuvant therapy, and it's given in patients that have much higher risk tumors, bulkier tumors, or lymph node positive disease. We give chemo before surgery. And that's very prevalent these days, and we have incorporated the Herceptin into that setting of treatment. So for those of you who don't have metastatic disease, you will see that this is being utilized right at the onset. And then 3 large trials, randomized trials, were done in 2005 to bring that therapy into a preventive setting, which is called adjuvant. That means surgeon has taken your tumor out. You don't have any sign of disease anywhere else. You're not dealing with metastatic disease, but you're benefiting from that HER2 new target drug like Herceptin for a whole year. Many of you have had that for a whole year, and that was intended to reduce the chance of your cancer coming back. Is it 100%? No. But in many patients, it was very effective, and we saw less patients develop metastatic disease. And those that develop metastatic disease, it differs if they developed it within a year or within many years after. And I'll go through that in the subsequent slides. And then other drugs came about. We found out that this HER2 target with the cell, that tumor cell is addicted. There is an addictive behavior to Herceptin, to the HER2 receptor. And we were able to cut off that addiction with now other drugs, Lapitinib. It was in 2005, and then subsequently TDM1 came about, and Pertuzumab and Neratinib. We found out that this epidermal growth factor receptors, they're not just one. There's a whole family of them. There's a HER1, there's a HER2, there's a HER3, HER4, and sometimes they come together as dimers together, or sometimes they come together, HER1 and HER4 comes together, and that's how Neratinib came about. These are different targets. Remember, Dr. Gray said there's a milieu of different arenas within that cancer cell that you can try to target at the same time. And that's how these came about. And we found out, for example, in TDM1, if you combine the anti-HER2 with another tubulin drug, like vinorelbins, we had used that for a long, long time. This one was an anti-tubulin drug with the HER2 that became extremely effective. However, as all of these multiple drugs were coming about, we didn't know how to use them. Should we even use one that has failed, say Herceptin, go to the other one? We found out, yes, that addiction is there, and we need to cut off that addiction. And we found out that different combinations of drugs may have different side effect profile or better responses. And how do we figure that? Through clinical trial. And then we ended up going through the 2010 preoperative trials of dual therapy. Like right now, that's the standard with Herceptin and Perjeta. And then with Perjeta is the Pertuzumab. And phase 3 trials of Perjeta was done in 2011. And by 2012 also, the competing drugs, TDM1 and capecitabine, Xeloda, many of you have been on it, with Lapatinib, they were put head-to-head. And then Pertuzumab preoperatively, all the way down here, was done. And Neratinib in 2015, one of the final winners of this, her family that we ended up utilizing. Now, the benefit of using the HER2 diagnostic test was first had to prove itself. So here, there were patients that were taken without the HER2 testing, and they were all given either paclitaxel and it was randomized, paclitaxel or Herceptin and paclitaxel. Randomized means that you don't know which arm you're gonna get, right, in the trial. And that's the best non-biased way we can do the testing. And we saw that the outcome was about the same. The probability of survival was about the same. But when you isolated here in the orange, the ones that had HER2 positive tests, and you gave them Herceptin plus the paclitaxel and compared it to just the paclitaxel, when you isolated the population that were HER2 positive, they responded greatly. Many more of them were alive. And that became the hallmark of this finding that, remember, I said in 1995, we thought that, people that were HER2 positive, they were the worst type. Well, it ended up now being that in Journal of Clinical Oncology, it was published that with HER2 positive, given drugs like anti-HER2, they actually outperformed the ones that were HER2 negative. And now we have recognized that those patients that are in fact HER2 negative and estrogen receptor negative are the worst type, not the HER2 positive ones, right? And you've had friends and families and loved ones that you've experienced that with, all due to advancement in science. So this is a brain tumor with multiple sites involved with cancer of the breast going to the brain. We know that in HER2 positive breast cancers, 50% end up with brain tumor. That's the highest of all types of breast cancers with regards to progressing into the brain. And yet, when you give the anti-HER2 drugs, it used to be that these patients lived literally 18 months, 6 months to 18 months. That was the lifespan of our patients. That's what we used to live through in 1995 and before that. And then when we ended up utilizing the anti-HER2, the life expectancy kept going up, and median at that time, when this was reported 2013, it was 2 years. And now we all have patients that are in the 7th year and 8th year and going. That's the promise of scientific discovery. So how does this epidermal growth factor receptor work? And our treatment, where does it work? If you can see this as a cell, cancer cell with the wall of the cancer cell. And the receptors, the HER family, they have a leg up on the surface and a leg down that they communicate actually with this, chromosome 17. Have you guys heard the bad chromosome? The bad chromosome 17, where the p53 genes are, these are the genes that encode a lot of the cancer growth and uncontrolled division. That's, after all, what cancer is, uncontrolled division of a normal cell that then develops those tentacles that tries to mobilize and move through the body, what Dr. Gray was showing. And the prongs were coming out with the HER family positive. They try to find new sites. So this antibody, which is in yellow right here, that's the antibody, that's the anti-HER antibody, Herceptin. It comes in when these HER families, they try to join together. And when they join together, they end up giving the signals down to the gene to mass produce these proteins, right? And cause the cell to keep dividing. These prevent that. They stop it. So different HER family, they try to stop it at either the two, for example, HER2 coming together, or a HER4 or a HER3 or a HER1 coming together with either one of them, which later on we found out that these are called homodimers. That means two of the same ones are trying to join together. And then the heterodimer, I'll show it later on. And that was the discovery of these different types of anti-HER2 drugs. And inside the cell and outside the cell, they cause that cascade of event that comes together. And then there are these other, the EGFR, whole EGFR family, that are within also intracellular domain of the cells that start acting. And you hear the word proliferation. That means just feeding the cancer cells to divide even further. So these homodimers, so we found out with lapatinib that there is a HER1 and HER1 coming together, or HER2 and HER2 coming together, and then it can be that 1 and 2 can come together. But either way, we found out that all of them, these are the ones at the cell surface receptor that downstream signal cascade starts. And we found out that by using drugs like lapatinib, that where it actually blocks the two of them, ERB1 and ERB2, which are really another synonymous names for HER2, one and HER2. Lapatinib then showed itself to be indicated in metastatic breast cancer only for patients with progression after trastuzumab, anthracyclines, these are like adriamycin, that red devil, and taxanes, because it had to show that it was better than Herceptin. And many trials ended up showing that it actually wasn't, so it got approved for after failure of Herceptin. So sensitivity to HER2, anti-HER2 drug in metastatic setting, how does that work? You may hear the word de novo, HER2 new metastases. There are patients that come in with no previous signs of it, and yet the cancer already has spread. At the first sign of, oh, I have breast cancer, they also find out it's in the liver, it's in the bone, it's in the lung. These are the primary sites that it usually goes to. These are de novo HER2 new metastases that are HER2 positive. They really need to be treated with trastuzumab, which is Herceptin, first. So they will be very sensitive to anti-HER2 drug. They will be sensitive to any anti-HER2 drug, but so far, Herceptin is the number one based on a lot of studies that has been done. And for those patients that develop metastases after the initial Herceptin was given, then if the initial Herceptin was given in preventive setting to them before they had the metastases, if it was a free interval of 1 year or longer, they seem to be more sensitive to anti-HER2 therapies than those whose disease progressed. Those that progressed after 1 year, they're more sensitive. You can actually use the Herceptin again. Those that are less than 1 year, it's less likely, so you better move on to the other ones. And that's why you may see variation of treatment based on, your physician's judgment, because they consider these things in how they choose to use different drugs at different times. A lot of patients come in and they say, but my friend is getting this. Well, because your friend's circumstances may be different. And then this phenomenon of HER2 addiction that I mentioned, that in a lot of chemotherapeutics that they work on the same spot, a lot of times physicians, they leave that chemotherapy and go to a different class, not in HER2 positive. We actually end up giving another HER2 drug. So we want to cut that addiction. And that was a great discovery for us and success that we've had with HER2 positive disease. So what are the pivotal studies? And many of you may have been on these studies. Many of you may have heard of these studies. There's many of them. And I'm proud at Kaiser Permanente that we were part of a lot of these studies. MA31, it showed that in combination with taxane, lapatinib, that's the Tykerb, was inferior to Herceptin. Cleopatra, pertuzumab added to trastuzumab and docetaxel, overall survival went up. Marianne's study, it was a negative study. Outcomes were similar for TDM1 and versus TDM1 plus pertuzumab and trastuzumab. So we're not using that combination together. Nifurt's study with the neratinib was as effective as trastuzumab, also differentiating itself from lapatinib. And Bolero 1 used Afinitor, and it was just too toxic. We ended up actually pulling patients off of this study earlier, way earlier. Amelia's study that we were part of with TDM1 as an option for patients whose disease progressed after Herceptin, and that got approval. Bolero showed benefit of everolimus added to trastuzumab and relevant, but at a significant cost of toxicity. So a lot of patients, and that's not a preferred agent that we're using these days. LuxBreast1 showed no benefit for afatinib. We looked at those EGFR domains, and we saw that it wasn't as effective as we like to see, so we're not using that. Theresa's study, a benefit for TDM1 in more heavily pretreated patients. So yes, we can use that after Herceptin failures. And also, EGF study in heavily pretreated patients showed a benefit of lapatinib and trastuzumab in combination, also although the toxicity of lapatinib is quite high. So you don't see too many of us go to that in first-time setting. In hormone receptor negative or positive patients, again, a lot of, this was in ASCO of 2018. We're using that earlier on with Progetta and Herceptin and taxanes, and hormone receptor positive patients where we can use the aromatase inhibitors with any of the anti-HER2, particularly with Herceptin, and those are in low volume diseases or in patients with quite a bit of comorbid conditions. So here I'm just going to quickly go through all of these studies, just summaries of them, where these anti-HER2 drugs really work and end up being utilized. This is the lapatinib study showing response rates over the Xeloda alone when you give it with combination. This is the same thing, showing it in more statistical terms and the exact percentage increase with overall responses. This is all the HER families that, Dr. Gray also alluded to, with particularly what he was alluding to is this cascade. What is the microenvironment doing? And how can we utilize? That's why you're ending up seeing some lung cancer drugs are now being used. Some CLL drug, idelalisib, that is used in CLL, that's targeting this one, now being tested in clinical trials. So each one of these targets have drugs that we can actually combine with the anti-HER drugs and be able to use them. These are the different domains, how they connect with each other when you use two anti-HER drugs, pertuzumab and Herceptin. These are the Cleopatra study specifically with the combination of the two anti-HER2 with the taxanes, and the study, this is the result of it, showing remarkably higher response rates, and that really brought this to as the first line therapy now that we're using. This is a TDM1, how a drug, this antibody, can be combined with the emtansine, with the antitubulin, and end up the active metabolite in here showed that it cannot cross the plasma membrane, and as a result, getting that magnificent effect. And in brain tumors that TDM1 was used, you can see before and after in each scenario, remarkable responses. And that really changed our clinical trial, framework. We used to always exclude brain metastases out of clinical trials, and now we were able to actually include them. This is the Amelia study, again, TDM1 versus capecitabine and lapatinib, and it showed that there we go. It showed that TDM1 was superior, so we're using that. And Catherine's study, the one that just came about last year, and we were part of it, the 3-year invasive disease-free survival rate was 88.3, combining them, the two of them, anti-HER, and using them up front. Now we're using that preoperatively, and then after, so that's the Herceptin and Perjeta plus taxane, and then afterwards, if the disease after surgery is done, and you've given the chemo before surgery, there is still residual disease, now we're using TDM1 successfully in those patients as adjuvant and for 14 more cycles. So quite a bit of prolongation of therapy, and that's how neratinib works, the newest drug that got approved, and I will not go into that. I'm given the signal that I'm running out of time. These are the different drugs. There's quite a bit of information, that milieu that is being tested. This mTOR, everolimus, was tested. It was very toxic, but many of them are still ongoing in different arenas and trying to impact a different protein synthesis to impact the cell growth and proliferation of these cells. So where are we now? This is where we are still. First line for HER2 positive, taxane, pertuzumab, and Herceptin, trastuzumab, and pertuzumab. Second line, TDM1 drugs. Third line, all of the other options of drugs, capecitabine, vinorelbine, lapatinib, and trastuzumab, other chemotherapies, any other chemotherapy with that, and endocrine therapy, neratinib, and of course, clinical trial. So in conclusion, you heard the emphasis of where we are with clinical trials. If it wasn't for the, brave souls of our cancer patients going through these clinical trials, we wouldn't know, the clinicians wouldn't know how to maneuver through this cancer. So the new drug right now, conjugate, what's in the works, it's DS820-1A. These are laboratory petri dish numbers, but it is the trastuzumab deruxtecan, that these are, again, anti-HER2 drugs that are being used by itself already. San Antonio Breast Conference covered some of these drugs, including this, and tucatinib, which is another anti-HER drug, and in combination with immunotherapies that Dr. Gray also alluded to. So these are what we're looking forward to. There's, of course, a lot of trials going on, but the most promising ones that we are expecting, based on the preliminary trials, that they're going to be effective, we think are these. And of course, we already have the neratinib, but neratinib is trying to make its way even to the forefront, so there's a lot of trials even as preoperatively and so forth. And you were given through Susan Komen Foundation speaker a lot of different sites. There's a lot of resources available to you. Clinicaltrials.gov has a lot of these pretty much nationally, what the trials are available to you. And the search engines have become smarter, where you can put HER2 new breast cancer and you can actually get specific trials that applies to you in metastatic setting. And it has like whether you're hormone positive, hormone negative, which one applies to you with HER2 new. And also, if you go to the website of any frankly, academic center these days, particularly like City of Hopes of the world, or, MD Anderson World, the UCLA website, and their search engines have gotten much, much better, user-friendly, and you can access a lot of these clinical trials. So in summary, much progress has been made, and challenges still remain with drug resistance, as Dr. Gray mentioned, and treatment-related toxicities that we're trying to maneuver and see which, combination of drugs are better tolerated. We know that the anti-HER drugs need to be combined with chemo. In fact, as an antibody, anti-HER drugs makes the chemo more effective. And that's why we're combining them with those drugs. And of course, the cost of the drug therapy and, getting into the clinical trial, that cost is not incurred by you. That's another advantage of the clinical trial. I'm going to open up to any questions you may have. That's a great question. That is true that it may be. We are in, with all the HER family now being discovered more and more, we're trying to understand that better. The rule of thumb for oncologists is that if a drug works, keep at it. Because you're trying to not necessarily abandon drugs that are effective, because clinical outcome is the most significant guideline of where you go. Unless the clinical trial shows that, during this time period, and this is studying the mechanism of resistance, right? What resistance occurred. But as long as you don't see resistance and, development of more disease, you're not to abandon that drug. And that's the hallmark of, otherwise you're going to run out of drugs really fast. And even so, you don't know that, should you combine the drugs, add something to it and not take that one away. But in absence of clinical trial, you cannot just experiment yourself.
Yeah, one of the things that Dr. Brasfield and I have agreed on is that we will milk every therapy as long as we can.
Yes.
Okay, we may sit through, a potential progression. It may be progressing, it may not be progressing, we don't really know. We may find out later, and I'll say, okay, let's just wait till next time, and we'll figure it out. And so being able to do that has extended, I think, my life, because I've been able to milk those, and my cancer hasn't, come up and, gobbled me up so far.
So, vaccine trials, we go far, far back in vaccine trials in terms of, it's a form of immunotherapy, essentially. And right now, it is thought about and it is being researched on, but unfortunately we haven't been able to hit all the targets. We're just learning of all the targets and the mechanisms of resistance to be able to do that. Many think of immunotherapy as a type of vaccine, but unfortunately, as you know, they all have a lifespan, and we're still waiting for that big target of the vaccine that completely eradicates. We've learned from microbial diseases that when we give vaccines, that you can still have breakthroughs of those, we learned that with measles, right? Just this year in northern part of the West Coast. So we know that with breast cancer also, there's going to be a process to that, but it is absolutely on the table with all of the trials. And every time we feel like we're going an inch, then we find out that, no, it's not complete. We're a step backward, but yet that's the building block for the next step to move on. And I have no doubt that what President Clinton said, maybe not now, but 50 years from now, may be in effect, that we're going to think of all of these after the vaccine comes up as something in the past. But it is actively being pursued. I can tell you that right now. I know several physicians at MD Anderson that are actively pursuing that. So we know that triple-negative breast cancers are susceptible to those immune blockade by the immunotherapy. We haven't, unfortunately, had that much success with immunotherapy in breast cancer with HER2 positive. However, the studies that I mentioned, they're trying to tag along in a different method with the stronger anti-HER. The ones that are, the reason it hasn't been is because, previously they've gone only to one member of the family. Now with like tucatinib type, they're trying to expand all the HER family and the EGFR family, all of those, the milieu of other factors in there that impacts the genome at a bigger spread. So hopefully we'll find out if that immunotherapy is going to work. But they, as you know, and there are several centers in Southern California, they are trying immunotherapy in clinical trial along with the anti-HER drugs that are more advanced than, say, just one of the HER families. So we have hope. Thank you for that. This phenomenon was exactly what I was trying to address in terms of if you've, gotten the cancer after the Herceptin for 1 year and a whole year has passed, you're going to be able to get back on Herceptin. Definitely, and it would work. And that's what studies have shown. And I believe that many physicians would probably add Perjeta to it at that point, since we have more information, or they may end up using T-DM1 at some point. So we'll see what the research shows to us. But at this point, there are 2 good drugs available, along with, say, Xeloda or any other chemotherapy, because those drugs that were approved up front, they can be used also for metastatic setting. If the cancer is within the year, then that means that it showed resistance to the Herceptin, so you try to use other anti-HER drugs. So definitely you will be on anti-HER drug. We do, because of the motility factor. One of the biggest things about HER2 is that there's specific genes that there are some genes that cause the cancer to duplicate, but then there are certain parts of the gene that works on motility of the cancer. That means movement of that cancer to progress and go to other sites. And that's why, some of the anti-HER drugs are trying to be combined with those so that, like TDM1, that was the whole basis of TDM1, to hit that tubulin, using an anti-tubulin, because it does cause duplication of those cancer cells, a lot more, and movement of it. There's this thing called VEGF, that's vascular endothelial growth factor, within the milieu of that, cell. And blocking that, the purpose of the VEGF is for the cancer cells to go through the bloodstream and revascularize, because they run out of blood supply. So, and then they die within themselves also. So having that anti-HER with the anti-VEGF together, it would end up, and some of the newest anti-HER actually hit the VEGF directly, and that's where it hopefully works on the brain progression. Yeah. Sure. So neratinib hits HER1, HER2, and HER4. So 3 of the HER family. And that's why it's really been a remarkable drug. And I really foresee that a lot of combination with neratinib is going to come about in many different studies. And if you research neratinib, you're going to see a long list of different clinical trials come up with that drug. And for that reason, by itself, it works amazing. I've seen that in patients, but it is a toxic drug. And it does cause quite a bit of diarrhea in patients. And if the physician is aware and lets the patient know ahead of time, they can actually use preventive anti-diarrhea agents and be able to be more successful. So it's been challenging to combine that drug with a lot of other chemotherapy, especially now that it's being used as like 5th line, 6th line, 7th line, when patients are hit strongly with a lot of different chemotherapy. But I have no doubt when used in the upfront with combination of the drugs, which the company is doing, we will have a lot more answers and more successes. It is in motion of really becoming like a chronic myelogenous leukemia. Those of you who know that disease or heard of it, it used to be that patients died literally within 3 years. And now it is a lifelong, living on that drug. We're going into the 27th year. So it's a moving target at this point, and I'm delighted that it is. Thank you for that question. That's actually something that I hear the most common from my patients. There's an institution, American Cancer Nutrition Research, and there are dietitians that are oncology specialized these days. There are not very many of them in the country, but that's something new that's come about. But the American Cancer Nutrition Research so far has shown to us that, cooking slower, even meats, if you're a meat eater, cooking slower, not barbecues, not things that causes a lot of oxidants in our food, that would be better. Vegetables, fruits, the biggest thing is weight management in breast cancer. And there's a preventive study also on aspirin right now. It's in the clinical trials.
At UC Irvine, by the way.
Yes. And actually at Kaiser as well.
Yes, okay.
And we've opened that study. And what it is that there was quite a bit of population of patients that were having myocardial infarction, heart attacks, and heart disease, that they were on aspirin. These were in terms of millions of patients across the country and across the world. So they went back and looked at those. Those are called retrospective studies. And they saw that when patients were on, those patients that were on aspirin, they had less prevalence of colorectal cancer way less colorectal cancer. They had less lymphomas in that population and less breast cancer. Those particular 3 cancers stood up. And also, then they went back and looked at patients that were, they had these cancers, and yet they had, because of heart disease, they were on aspirin, whether it was stroke or heart disease, and for any reason on aspirin drug, then they ended up seeing that recurrence of their cancer was lower than age-adjusted regular population of those cancer patients. So that's another thing. But please don't take it off clinical trial. Do it on the clinical trial. Join the team.
Yeah, that's the problem. We're having a really hard time. It's called the ABC trial, I believe it is,
yes,
for the aspirin trial. And the thing is that people say, I don't want to go in this trial because I can just take aspirin, so why go on the trial? But the thing is if we don't have people in the trial, we're not going to learn. And the thing is, drug companies are not supporting this research because aspirin is something everybody can buy.
Right.
And so we need people to actually be part of this particular clinical trial in order for us to be successful and get the answers to these questions that we think we're going to get some pretty positive answers to, but we've got to have participation in trials in order for that to happen.
Depends on the stage of the disease, depends on whether you're at the onset of the treatment. If you're HER2 positive and, depends, for example, if the tumor marker is positive, then you can actually, just do the tumor marker and not images. If the tumor marker is negative, some people are not the CA15-3 or CA27-29, they don't even secrete it. So you're not going to do that. You're going to do studies, imaging. There's actually a clinical trial on this issue that is trying to assess whether we can, instead of frequent imaging that a lot of, unfortunately patients go through, which have their own bad effects, whether marker studies could replace those. So it depends, and that's being studied to see how often and when. But right now, initially, particularly when you are on a drug at the onset of it and you want to see, is it working, is it not? It's not the one-time marker that shows that, it's the trend of that marker. And you can actually decrease that once you're comfortable that it's, initially a lot of physicians may use every month, then they go to every 3 months. But most physicians in metastatic setting, they would do every 3 months, those lab work.
Well, that sounds right, because that's what my oncologist does.
Similarly, scans are, remember, labs and scans, labs are done, particularly when you're on chemo, to direct the chemo. Tumor marker is done to assess response. But, CBC and liver tests, kidney tests, that kind of stuff, those are done to direct your therapy. It's not done to see how your cancer is doing. Marker does. Imaging the same way. You want to know how the cancer is doing. So if the marker is positive and the marker shows that it's going down, you don't need images to tell you unless you're developing something. But you do, developing some symptoms that the doctor has to do that. Always the symptom and the exam supersedes anything. But if the marker shows good and your exam is good, you don't need to be going under CAT scans every, frequently every month or every 3 months or even 6 months.
That's actually something I had to build trust with my doctor who is in this room, is that you don't have to have a scan all the time.
Yes.
You don't have to be scans, scattered or have the scanxiety as much. You need to know what your symptoms are and how you feel. You need to point out, does your back hurt a lot? Are you getting dizzy? Are, all these other symptoms. When you go to the breakouts on brain, bone, liver, and visceral and lung, make sure you ask about, what are the signs of getting metastasis in those particular areas, because that's something that Komen needs to focus on more. We don't teach people what to look for. as far as when you might progress. And that's something that I'm going to be pushing for and continue to push for. It's not like we're scaring people who have early stage disease, but you need to know, you need to be informed. And at this point, what I'd like to do is thank Dr. Brasfield for her presentation. Thank you.